All right, welcome back. Now we're going to be talking about patient assessment and history taking. So, for the first thing, I just want to go over a general overview of the order of operations, right? So, first off, we start off with a scene size up. We always want to make sure that our scene is safe. There's multiple things that we want to take in consideration whenever we're doing our scene size up to make sure that everything's safe for us, making sure we have the right PPE on, making sure that we are conscious of any hazards that's on the scene, make sure that we have the right resources, things of that nature. Next, we're going to go into the primary assessment where we're going to be assessing for any type of life threats that our patient may have and treating those immediately. Once we've completed our primary assessment, we'll wrap that up by figuring out what priority our patient is. Also figuring out if our patient is a trauma patient or a medical patient, and then following those tracks. And then treating the patient for any injuries or giving them any type of medication that they may need to close off that secondary assessment. And lastly, we're going to make sure that we're reassessing our patient, right? Because if there are any changes in our patient status, we're going to go right back on up to that primary assessment, reassess those ABCs, make sure there's no life threats that we need to take care of, and then treat the patient accordingly. Okay. So to get a little bit deeper into scene size up, I kind of talked about some of these things, right? We want to make sure we have the right standard precautions, have on the right PPE. So based off of what's going on our scene, we're going to change up what PPE we may wear. Usually we want to have on gloves and glasses for all patient contacts to protect ourselves, but in some cases we may want to throw on a gown or a hazmat suit. So just based off of your scene, you'll make a decision on what PPE you want to put on. Next, we're going to be looking for safety hazards. So if you're at the scene of an MVC, you have broken glass around, you may have chemicals spilling out of the vehicles, and things of that nature. So you want to take all of those things into consideration um, and make sure that you're safe when treating your patient. Another thing that people don't always think about is if we have irate people on the scene, or if the patient is being violent, we want to make sure that we have all of those things controlled. That's where, at the very bottom, where it says determining the need for additional resources comes into play. We'll call in whoever we need, whether that's fire, special rescue teams, PD. We'll call them in to kind of help us on the scene. We also want to take the time out to determine the mechanism of injury or the nature of the illness for our patient. That way we kind of have an idea of what to expect, what type of injuries to expect, what type of treatments that we may be expecting to give our patient. We also want to look at how many patients do we have, because if we have multiple different patients, that's going to be a mass casualty incident potentially, and we want to make sure that we have the right amount of resources for them. We may be calling in for additional units to come in and help us out. Other things to consider when it comes down to additional resources is look at the terrain, look at where you're at. If you have to go into the woods and look for somebody, or if somebody has a wreck and goes off the side of the road, you may need to call in some other resources like tow trucks or fire to pry the car open, or you may need to call in a special hazmat team to deal with chemical spills. So just make sure that you're keeping all of those things in consideration when you're doing your scene size up. Next, we're going to move into our primary assessment of our patient. So when we first lay eyes on our patient, just from the door, if we're in their house, we're going to kind of get an idea of our general impression of our patient. This kind of lets us know like what level of urgency that we may need to deal with this patient, right? If they look like they're in a whole bunch of distress, then we may need to move a little bit more urgently to deal with them. Or if we see obvious signs of shock, just from the door, just looking at them, we know that we need to be a little bit more urgent in the way that we go about treating this patient. We're also going to be taking in consideration what is the mechanism of injury or nature of illness. We can't completely depend on our call notes that we got So sometimes we may need to wait till we lay eyes on our patient to kind of figure out if they're medical or if they're trauma. We may not even figure that out until a little bit later in our assessment, but we're going to go ahead and start processing that information now. Some other things to keep in mind or to take a look at is going to be our patient's mental status. We're going to be using the AFPU acronym to go ahead and kind of figure out what our patient mental status was. Are they alert? Are they responsive to verbal? Are they responsive to painful stimuli? Are they unresponsive completely? All of those things will kind of determine how we continue to treat our patient and how we go about our assessment. Next, we're going to check their airway. When we're checking the airway, we want to make sure that if our patient is conscious and they're talking to us with ease, we know that their airway is patent. And so we don't really have to worry about airway treatment on those patients. For our patients that are unconscious or have altered mental status, we may need to open their airway with either a head tilt chin lift or the jaw thrust maneuver. Notating that we're going to be utilizing that jaw thrust maneuver if we suspect any type of trauma with our patient. Once we have that airway open, we're going to be looking and seeing if we hear any breath sounds, if we feel any air movement, and then we're also going to be also looking for any type of foreign objects or checking to see if there's anything that we may need to suction or remove from the airway. Next, we're going to be moving on to breathing. This is when we're going to get into that look, listen, feel, checking that respiratory rate, rhythm, and quality that we talked about in the vital signs assessment. Based off of what we're seeing here, we're going to start making decisions on if we're going to place oral airway adjuncts or nasal airway adjuncts. Also, if we're going to be oxygenating our patient or if we're going to be bagging our patient. At this moment, we can go ahead and get our partner to slap on a pulse ox so to kind of help us with that decision. We're also going to be bearing their chest if they're a trauma patient so that we can kind of check the chest out, see if there's any injuries to the chest, and treat those accordingly. We're going to be looking at circulation. We're going to check their skin. We're going to be checking their pulse. And we're going to be checking to see if there's any type of bleeding going on in our patient. For pulse, as you remember, we're going to be looking at rate, rhythm, and quality of their pulse. We're also going to be looking at their skin signs. Skin is going to be color, temperature, and condition. And then after we check all of those things and treat the life threats that we find, we're going to be establishing our patient's priority. Is this a high priority patient or is this a low priority patient? For our high priority patients, we want to go ahead and load them and go as quickly as possible. For our low priority patients or stable patients, we want to go ahead and stay in play is the term I like to use, but we're going to stay on scene and assess them further there, and maybe even start treatment on scene before transporting them to the hospital. Like I said previously, primary assessment is all about managing these life threats. On the screen, you can see some examples of life threats that we're going to treat. These are specific to the chest, right? That we're going to kind of find in the breathing section. So when we bare that chest, we may notice that there's some type of a puncture wound. Immediately, we want to go ahead and cover that with our gloved hand. And then we want to get some type of occlusive dressing on top of it and tape it on 3 sides so that we can burp it as needed to help air be released from the chest. We don't want all that excess air going in the chest because it can eventually cause a lung to collapse or cause decreased cardiac output. Next, we also want to be checking for chest wall instability. So one of the things we look for is paradoxical movement, and that's going to be when you have 2 or more ribs fractured in 2 or more places. And that's what that's going to look like is whenever our patients inhale and that chest moves outward, that section is going to stay inward. And then whenever they exhale and the chest moves inward, that section is going to kind of pop out. That's also called a flail segment. Okay. One of the other things that we're going to be looking for and checking for is any type of major bleeding. we want to immediately stop that. So again, we're going to immediately place our gloved hand with some gauze over that wound to try to stop the bleeding. We want to make sure that we're applying pressure in this case. If the pressure is able to stop the bleeding, then we're going to go ahead and do a pressure wrap where we put some more gauze on top of that, and then maybe use like an ace bandage or something to keep the pressure on top of that wound. But if for whatever reason the bleeding is not controlled, then we're going to be applying a tourniquet. And for a tourniquet, we're going to place that about 2 inches above the injury. If 2 inches above the injury ends up being directly on top of a joint, then we're going to go ahead and put it right above that joint. Okay. What we also want to be checking for and making sure we're paying attention to is if our patient is apneic or pulseless, we want to do immediate resuscitation in those cases. Okay. We want to immediately start ventilating and recognize early if our patient is in cardiac arrest and immediately start CPR. One thing to note with the primary assessment is that we're going to change things up just a little bit if our patient has a trauma injury. So, in the case of a trauma patient, we're not going to go the typical ABC route. We're actually going to do XABCDE or use the MARCH acronym to kind of guide us in doing our primary assessment. All that is I'm dealing with the bleeding first, and then I'm going to do my traditional ABCs. And then we're also going to be taking a look at any type of disabilities. At this point, we'll assess pupils, we'll assess neurological deficits, and then we'll also be assessing for any type of hypothermia or environmental related injuries. So once we've done our primary assessment, now we're going to be determining our patient's priority, right? For our unstable patients, those are going to be our high priority patients. For those patients, we want to do a rapid secondary assessment and then package them to get quickly transported to the hospital. Always immediate transport for our unstable patients. For these patients, we want to be on the scene for no more than 10 minutes. We want to really be loading these patients and get it moving as soon as possible because they need to get to that definitive care. For our stable patients, we can stay on the scene, assess them a little bit further, and we can do a full secondary assessment for these patients or do a focused secondary assessment based on their chief complaint. Next, we're going to kind of get into our secondary assessment. Like I said, we're going to be doing this differently depending on what patient that we have in front of us. But all of the secondary assessments is going to include some type of a physical exam, getting a baseline set of vitals for our patient. Baseline is just our first set of vitals. And then we're also going to get a history on our patient. Make sure that you tailor your assessment to the needs of the patient or what you suspect their injury is or what their complaint is. Whenever you're doing your assessment too, make sure that you're moving in an orderly fashion. We have multiple different acronyms to kind of help you along the lines for history, and then for the physical exam, you want to make sure that you move systematically from head to toe. So first, we're going to be looking at our vital signs, right? So if we want to get a full set of vitals, that's going to be checking their respiratory, checking their pulse, checking their skin condition. In the case of a pediatric patient under the age of 1, we'll be checking cap refill. For our older patients, we'll be doing a blood pressure. We're going to be assessing pupils, checking SpO2, getting a body temperature if you have a thermometer, and we're also going to be getting a blood glucose level. If our patient is complaining of any type of pain, we'll go ahead and get a pain scale on that patient. And then if we have the ability to note capnography, we're going to go ahead and get them attached to capnography. So now we're going to obtain some history on our patient. This is the time where you get to put on your detective hat. You're Sherlock Holmes and you're on the case. So let's figure out what's wrong with this patient, right? We're going to use sample and OPQRST as a way to kind of guide us through this history taking, right? Make sure that whenever you're using these acronyms that we're not just limiting ourselves to one question. We want to do a mixture of open-ended questions and closed-ended questions. Use open-ended questions to get an idea of what's going on, and then you can use closed-ended questions to verify certain pieces of information. We also want to kind of use the echo technique um, to make sure that we are hearing our patients correctly, and that we're getting all the correct information. There are a lot of diseases out there that are very similar and they may have the same signs and symptoms. So we want to make sure that we're really asking the hard questions and asking multiple questions to try to get to the bottom of what's going on with our patient. All right, so S is signs and symptoms. That's pretty simple and straightforward. You'll be assessing signs when you do your vital signs, and then your patient will be telling you their symptoms, right? It's something that we can't see or measure. We're also going to be checking allergies, especially if we plan on giving medications to this patient. We definitely need to make sure we know what the patient is allergic to. Medications, and past medical history. If your patient has a bag of pills somewhere, if they don't know their medications right off the top of their head, make sure you grab those pill bottles, take a look at them, ask the patient what they take that for, and just make sure that you get a full history as far as medications. Also, with medications, I want to stress to you that you find out if they took their medications recently. Sometimes, if they haven't taken their medication, that could be a very obvious ding ding, this is why this is going on right now. You haven't taken your medicine in the last month, you know. We also want to know last oral intake. That kind of plays into when the last time they took their medication, but it also is about if the last time that they had something to eat. We want to know about events prior to this. Were you sitting on the couch? Were you being active? What were you doing when all of this started? Next, we want to go down our OPQRST, and we're going to be looking for the onset. Onset is when and how did these symptoms begin, right? Was it associated with a particular activity? It's very similar to the E, but if there's anything that they left out when you asked about E in sample, onset is where we're going to get the rest of that information. Next, we got provocation and palliation. That's going to be what makes our symptom, make the patient's symptom better or worse. Um, does moving around make it worse? Does laying down make it worse? So, or does that make it better? We want to make sure that we're notating all of that. Next is going to be quality. And that's going to be just strictly a description of the pain. We want this to be a kind of an open-ended question. Hey, can you describe the pain for me? And if for whatever reason the patient is having a hard time describing it, at that point we can kind of throw out some hints. Is it sharp? Is it dull? Is it pressure, right? Next, we're going to be looking at radiation. Does this pain move anywhere? Do they feel pain in any other place? Sometimes they have chest pain, but it radiates to the jaw or to the left arm. So that's a good indication that our patient may be having an MI. Next, we're going to be looking at severity. That's when we're going to put that on a scale of 1 to 10. I always like to throw in there 10 being the worst pain that you could ever imagine or the worst pain that you've ever felt. And then lastly, time. What time did all of this start? How long ago was all of that? Is it consistent? Does it come and go? Those are all the things that you could be asking your patient to kind of get a good, strong history on them. Now, getting a little deeper into our secondary assessment, we want to be looking at if we have a trauma patient or a medical patient. For our trauma patients, we're going to be primarily focusing on meta, mechanism of injury to determine how we go about treating this patient. For our patients that have that significant mechanism of injury or altered mental status due to the trauma injury, we want to go ahead and make sure we get inline stabilization of their head as soon as possible. We're going to be calling for that ALS backup, which they can benefit from because ALS can do more than you can as an EMT. We also want to reconsider our transport decision. Does this patient need to go to a trauma center, right? And also, do we need to call in additional resources, like calling in for a helicopter, right? A life flight. We want to make sure that we are reassessing any type of mental status changes. We're also going to perform a rapid secondary assessment on these patients. For the rapid secondary assessment, where it's going to be just like a deeper primary assessment, along with looking for any other injuries that could potentially cause fatal wounds. We want to try to treat and stabilize as much as we can. For this, we're doing a detailed head to toe, from head all the way down to the toes, systematically moving, checking each area of the body. We're going to be looking at vitals, and we're also going to be getting a history. For the history for these patients, we want to make sure that prior to leaving the scene, because our patient is altered, they can't give us a good history on themselves, right? Or if they're completely unconscious, they can't give us a history at all. So we want to make sure that we are reaching out to any family members or bystanders on the scene prior to leaving to get as much history as we can on the patient or find out what happened. Next, we're going to be looking at transport, getting them out of there as quickly as possible. We don't want to be on scene with these patients no more than 10 minutes. And then lastly, we want to reassess very frequently to make sure that we're assessing for any change in their ABCs or any change in their mental status. For our non-significant mechanisms of injury or our patients that are not altered. So for instance, a guy who rolled his ankle might be somebody who we would use this branch of the tree for. We're going to look at the modified secondary assessment for this patient. We're not going to do a full head to toe on him. We're going to focus on where he's complaining of an injury, his ankle. We're going to try to stabilize that, and then we're going to get moving. We're going to get some vitals. We're going to get some history. We're going to transport our patient to the hospital, and we're going to reassess them. We don't have to reassess them as frequently as we reassess our unstable patient, but we do want to make sure that we're reassessing. For our medical patients, we're going to be looking more at mental status to kind of guide us on which direction to go with our assessment. For our patients that are alert and oriented, it's all about getting that full and complete history, using their signs and symptoms, using OPQRST, using sample to make sure we get a full picture of what's going on. Then we're going to do a modified secondary assessment where we're going to be looking at the body system that they're complaining of. So for our patient with chest pain, we're going to assess the chest, assess breathing, listen to lung sounds, um, and make sure that our patient is perfusing well. Next, we're going to be looking at vital signs on this patient, and then we're going to make a transport decision, right? Depending on what their complaint is or what we suspect is going on with the patient, we may decide to bring them to a different hospital. For instance, if our patient is having an MI, we want to bring them somewhere where they can get reperfusion to those vessels. And if our patient is having a stroke, we want to bring them somewhere where they can get thrombolytic therapy. And then we also want to consistently reassess on these patients also. For our unresponsive patients or our patients who have altered mental status, we're going to perform a rapid secondary assessment. So again, we're still going to do that head to toe assessment using that systematic approach and do a good assessment of these patients because they can't tell us what's going on with them. So we have to look for the clues in their body to tell us what's going on with them. We're going to assess their vital signs. We're going to put them in a proper position depending on their complaint, right? If we need to be bagging these patients, then we want to have them laying supine versus if we have a patient that's maybe just a little bit altered, we can kind of put them in that semi-Fowler's position, right? We'll make sure we obtain a good history on them. Again, for these patients, if we have them in their altered, we want to make sure we get a good history from family members and bystanders, or other medical professionals who may be on the scene before we transport them out. And then we want to make sure we reassess. Um, for reassessment. For our unstable patients, that's going to be our patients with that significant mechanism of injury or altered mental status. In the case of our medical patients, we want to make sure that we are reassessing them every 5 minutes. And for our unstable patients, for our stable patients, we are going to want to reassess them every 15 minutes. And that's going to be our patients who do not have a significant mechanism of injury and who are alert and oriented. So, just to get a little bit more into reassessment, along with reassessing them every 5 to 15 minutes, depending on if they're stable or unstable, we want to be checking their mental status, reassessing their airways. So, everything that we did in the primary, we want to reassess their vital signs. We also want to see if their chief complaint changes, if their signs and symptoms are relieved, if the medication that we gave has some type of a side effect on them. Big things that we want to notate is if they're improving or deteriorating. We can kind of see that in the vital signs that we get on the patient. So just be mindful of that. That's why we want to get multiple sets of vitals, because it's going to show a trend in our patient status, right? It'll let us know if what we're doing is helping our patient or if they're continuing to decline, even though we're giving them the proper treatment. One big thing to note about reassessment is if I have a patient that started off stable and then throughout my assessment they become unstable, we're going back to that primary assessment and we're treating them like they're a brand new patient. So ABCs all over again, treat the life threats, and then continue to work through your assessment.